Surgery of the Ear by Glasscock and Shambaugh. Chapter 28 Tympanoplasty, Tympanic Membrane Repair. Preoperative evaluation. A complete history and head and neck examination should be performed on all patients prior to the surgery. The otoscopic examination is best accompanied with the operating microscope. An audiogram within 3 months prior to surgery is essential and should consist of pure tone, air, and bone conduction thresholds as well as speech discrimination scores. All hearing test results should be confirmed with tuning fork testing. For an actively draining ear, the external auditory canal and tympanic cavity should be cleaned of any purulent material within a small otological suction under the surgical microscope, and the patient should be instructed to take water precautions. For refractory cases, irrigating the ear with a solution of 1.5% acetic acid using a bulb syringe 2 or 3 times a day can be helpful. The solution should be brought to the body temperature prior to irrigation in order to avoid caloric effect. Following irrigation, the ear should be allowed to drain and antibiotics drops covering Pseudomonas aeruginosa should be instilled. Digital pressure over the ipsilateral tragus should then be applied several times to force the antibiotic solution deeper into the ear canal and middle ear. Oral antibiotics with activity against Pseudomonas aeruginosa may also be considered for patients not responding to local treatment. Culture and sensitivity should be obtained for refractory cases, immunosuppressant patients, and when an unusual infection process such as tuberculosis is suspected. Cholesteatoma cases may fail to respond to local treatment prior to surgery, and although most surgeons prefer operating a dry ear, there is no contraindication to perform tympanoplasty in the face of active infection. Often, cholesteatomas must be treated surgically in order to attain a dry ear. In addition to the aforementioned measures, effort should be made to control any conditions predisposing to failure, such as obstructive adenoiditis and adenoids and recurrent tonsillitis in children, allergic rhinitis, sinusitis, and nasal obstruction secondary to deviated septum. These upper respiratory tract conditions can directly influence eustachian tube function and therefore the outcome of any surgery in the tympanic cavity. There is no preoperative test for eustachian tube function. The Toynbee's test and the Valsalva maneuver can detect patency of the eustachian tube, a finding that does not correlate with normal function. Furthermore, poor eustachian tube function prior to surgery may improve following tympanoplasty by removing middle ear disease processes such as polyps, granulation tissue infection, and the insertion of a sheet of absorbable gelatin film. For patients who develop middle ear effusion following tympanoplasty, a laryngotomy and ventilation tube insertion can be done as an office procedure 2 months after surgery. Imaging studies. Dry chronic otite central perforations require no preoperative imaging. In cases with cholesteatoma, atelectasis, and chronic drainage, high resolution computed tomography (CT) of the temporal bones may be helpful in determining disease extensions, possible intracranial involvement, degree of mastoid pneumatization, the type of surgery approach to be used, presence of labyrinthine fistulae, fallopian canal anatomy, as well as tegmental defects if a tegmental defect is detected by CT. The diagnosis of the brain herniation can best be established with a magnetic resonance imaging MRI study of the temporal bone. Informed consent. Prior to surgery, patients should be properly informed regarding the nature of their disease process, treatment options, and the proposed surgical procedure, including expected outcomes, potential risks and complications, and the possibility of a second stage procedure. Brochures describing the disease process and proposed surgical procedure and post operative care are very useful. Office chemical meringoplasty. This technique was introduced by Rosa in 1876 and was popularized by Dalaki in the 1950s, who reported good results. Cooperative patients with small, less than 4 mm central tympanic membrane perforations may be considered for this procedure. Marginal perforations, a small ear canal, active infection, the presence of cholesteatoma, a conductive hearing loss due to an ossicular problem, and the presence of extensive tympanosclerosis in the tympanic remnant are contraindications for this procedure. Under the microscope, the edges of the perforation are cauterized with trichloroacetic acid applied by a metallic applicator with a small amount of cotton wound tightly at its tip. Chemical cauterization destroys the squamous epithelium that has grown over the rim of the perforation and in so doing exposes fibroblasts and promotes healing of the lamina propria. Silver nitrate is an alternative chemical agent that can be used for this purpose. The perforation is then covered with gel foam or gel film, Pharmacia or Upjohn Company, Kalamazoo or cigarette paper patch. Local antibiotic drops are prescribed and then the procedure is repeated every 2 weeks until the perforation is healed. A 64% success rate has been reported with this technique. Alloplastic patching. Tauby in 1853 and Yearsley in 1863 first reported the use of alloplastic materials for hearing improvement in patients with tympanic perforations. Recently, a very soft silicone device in the shape of a sealed tympanostomic tube placed in the office has been found to be safe and effective alternative for treating tympanic perforations with an intact ossicular chain when surgery is contraindicated or is refused by the patient. Contraindications for this device are active middle ear infection, cholesteatoma, and eustachian tube dysfunction. Histopathology of tympanic membrane perforations. In a histopathologic study of chronic tympanic membrane perforations, it was found that squamous epithelium often extended medially from the perforation edge. Epidermal growth factor, hyaluronan, fibronectin, and other glycosaminoglycans, all of which are known to be present in wound healing, were only scantily present. These findings could explain the arrested healing and cessation of spontaneous closure associated with chronic perforations. Accordingly, complete removal of the perforation rim prior to grafting is mandatory to avoid any extra extrapment of the epithelium within the middle ear. In an experimental animal study, the epidermis is the first layer that closes an tympanic membrane perforation. Healing of the fibrous layer occurs secondarily, and the site of response in this layer is related to vascular distribution in the tympanic membrane. This process begins within 48 hours and is complete within 9 days. The epithelial layer of the healed human tympanic membrane does not contain basal cells, confirming its origin from migration from the periphery and not by in situ perforation. Epidermal growth factor has been reported to promote healing of chronic tympanic membrane perforations. In animal studies, hyaluronic acid and heparin have been found to improve the healing rate as well as the quality of the scar. Grafting materials. Presently, the most commonly used grafting materials for repair of tympanic membrane perforations is temporalis fascia. Another grafting material introduced by Moon in 1970 with excellent graft take is areolar tissue obtained from the area overlying the temporalis fascia. This grafting material has been used extensively by Glasscock and is highly recommended by the author because there is minimal or no bleeding during removal due to its location in an avascular plane. It is easier to handle during graft placement, and in case of failure, the temporalis fascia is still available for use. Tragal and auricular cartilage, as well as perichondrium, are other very commonly used grafting materials. Surgical results with these grafts are similar to those obtained with temporalis fascia. Other reported autologous grafting materials associated with excellent results are fat and scar tissue. Recently treated acellular dermal homografts, all derm life cell corporation, Branchburg NG, and Tutopatch Tutogen medical xenograft derived from bovine pericardium have afforded results similar to those obtained with temporalis fascia, perichondrium, and cartilage. These homografts may be considered for revision cases in which autologous grafting materials is no longer available. For cases with total perforation, cholesteatoma, and atelectasis, and especially for revision cases, the author prefers to use cartilage shield grafts obtained from concha simba. This technique is described in cartilage Tympanoplasty section of this chapter. Anesthesia for tympanoplasty. General anesthesia is preferred for all chronic ear surgery procedures and is particularly helpful for children and excessively apprehensive patients. General anesthesia can be used in outpatient setting as well. For such cases, long anesthesia machine circuits are used to allow the anesthesiologist to be positioned at the feet of the table. This allows adequate room for the surgeon's leg beneath the table. The blood pressure cuff should be placed on the opposite arm to the ear undergoing the surgery so it does not interfere with the surgeon. If the facial nerve monitoring is used, paralyzing agents should be avoided during anesthesia. In cases of meningoplasty or when general anesthesia is contraindicated, local anesthesia with sedation can be used as well. Positioning of the patient. The patient is placed close to the edge of the table in order to prevent the surgeon from hyperextending his or her arms. The patient's body is properly strapped on the table and both arms are padded and trunk close to the body. The head is turned approximately 120 degrees away from the surgeon and is supported with a folded towel placed between the table and the contralateral cheek. No donut shaped pillow is necessary. An operating table that can rotate along its long axis is essential in order to allow the whole body of the patient move away from the or towards the surgeon to achieve optimal visualization of the surgical field. Rotating the patient towards the surgeon allows better visualization of the posterior area of the surgical field, whereas rotating the patient away improves the inspection of the anterior surgical field. A hydraulic chair is very helpful for the surgeon because it allows changing of visualization angles with minimal effort. Position of the nurse and surgical microscope. The nurse and the instrument table are placed across from the surgeon, and the surgical microscope is positioned at the head end of the table. Facial nerve monitoring. Although facial nerve monitoring is not a substitute for thorough knowledge of facial nerve anatomy, the author uses it in majority of otologic procedures. In cholesteatoma cases in particular, dissection and removal of the cholesteatoma matrix from the facial nerve can be done in a more controlled fashion, especially in cases of fallopian tube dehiscence. Prophylactic antibiotics. In an uncomplicated tympanoplasty case, prophylactic antibiotics are unwarranted. However, for a draining ear, antimicrobial coverage is recommended prior to surgery. Frequent irrigation of the surgical field during the surgery removes devitalized tissue and perhaps reduces bacterial colony counts and subsequent infection. Hemostasis. Complete hemostasis is imperative in autologic surgery and can be accomplished as follows. Discontinuation of aspirin and anti inflammatory medications 10 days prior to surgery. Discontinuation of anticoagulant treatments such as Plavix reduces prior clearance by the patient's primary care physician. Injection of post-auricular incision and ear canal with lidocaine 2% xylocaine with 1 is to 1 lakh epinephrine at least 10 minutes prior to making any incision. Availability of autologic electromicrobipolar and conventional cauteries. Gel form soaked in undiluted epinephrine, a dry surgical field can be accomplished by leaving gel form soaked in epinephrine in the middle ear while obtaining the graft. Availability of diamond burrs of various sizes for control of bleeding from the bone. Frequent irrigation of the surgical area with a saline solution. Prepping of surgical area and a 2 to 3 centimeter area of hair above and behind the auricle is shaved and then rubbed with an alcohol solution to degrease the skin. Tincture of benzoin is applied and 3 number 1010 drapes are placed on the skin to keep the hair away from the surgical area. The post-auricular area is injected with 3 to 4 centimeter cube of lidocaine 2% xylocline with 1 is to 1 lakh epinephrine for hemostasis. The surgical area is cleaned with iodine soap and solution and blotted dry with sterile towel. The patient is draped with sterile paper drapes and 3 plastic drainage bag with self-adhesive is applied at the most dependent segment of the surgical area. Irrigation, suction tubing, and cautery lines are wrapped in a cloth towel and secured on the drapes with towel clips. A compartmentalized plastic pouch is attached to the drapes of the Mayo stand to accommodate the suction tips and electrocauteries.